Hey everyone, this is Tracy and Womana, and I am your coag coach in hematology. I am back with the second half of this coag vignette that we talked about last time, and this time we're focused not just on the differential, but we're really focused on making the diagnosis. So remember, the case is a case of an elderly woman in her 90s who has coronary artery disease and deep vein thrombosis. She has a history of atrial fibrillation and is on Apixaban. She has a prior fall with a subdural hemorrhage and today presents with hematuria and hematoma. The focus is on hematuria and hematoma. Now, I want you to commit to a diagnosis. Does she have Apixaban toxicity, hemophilia A that is acquired, so factor VIII inhibitor, hemophilia B, or von Willebrand disease? Okay. Let's talk about the keys to a diagnosis. So you're going to be asking questions to tell you the history, and you're also going to be doing a diagnostic evaluation. The medical history helps you sort out how long this has been going on and what the character of the bleeding is. It also helps you sort out whether this is a problem she's had all her life or this is a new problem, so congenital versus acquired. The family history also helps you sort out congenital versus acquired. Social history helps you think about what other things might be causing underlying illness that's driving this presentation. Does she have liver disease? Does she have a history of alcohol abuse that may indicate liver disease? Is she someone who has poor nutritional status, and so she's not cooking for herself, she's lost a lot of weight, has no one around to help her? Is this vitamin K deficiency? Medications are helpful because you want to check which medications may be driving a bleeding disorder. Okay. Then you want to look at the physical exam because finding petechiae makes you think, oh, well, thrombocytopenia must be present even before you have the lab evaluation. The lab studies are going to be key in making the diagnosis. And imaging would be helpful if she has extensive bleeding and you want to evaluate the extent to which she's bleeding. Okay, for this particular case, the key is going to be in the medications and the lab studies. Let's take a look at her medications. She's on a ton of them, but we want to focus on just the key ones that could be causing problems. So if she's on Apixaban, that's important. This could all be explained by Apixaban. But she's also on amiodarone, which could cause thrombocytopenia, rarely. She's on sertraline, which could cause platelet dysfunction. She's taking ascorbic acid, so maybe she doesn't have vitamin C deficiency. She's also on a multivitamin with minerals, so maybe this is not vitamin K deficiency. Okay, how about the lab evaluation? When we look at her CBC, we notice that 2 months ago, her hemoglobin and hematocrit were normal. Today, she's dropped a couple of grams, so she's definitely bleeding. No joke. The platelet count is normal, so it's less likely as liver disease or an underlying bone marrow infiltrative disorder. And her MCV is normal, and that tells us that the bleeding is acute to subacute. How about the chemistries? The chemistries are largely normal. We do see that her creatinine is a little bit elevated, but not significant enough to cause her bleeding. And then when we look at her other chemistries, her AST and ALT are within normal limits, so this is unlikely to be liver disease. She does have a little bit of albumin that's low, so there's some nutritional issues there, but probably not significant enough, okay? All right, how about her coag studies? Now, this is important. We note that her prothrombin time is prolonged, and her PTT, her activated partial thromboplastin time, is also prolonged. This is important. Could this all be explained by Apixaban? That's important because Apixaban can prolong the PT and the PTT, but it might not. And what's going to be important is to go back in her history and say, well, she's been on Apixaban for a while. In the past, was her PT prolonged? Was her PTT prolonged? And then you want to say how much Apixaban is on board anyway, right? So looking at the Apixaban assay, you can see that her Apixaban assay is it's elevated. So there's Apixaban on board, but it's not that high. And so what I'm seeing here is a little bit of a disconnect between what I'm seeing in the PT and the PTT and the level of Apixaban that's on board. So I don't want to just say this is Apixaban. I actually want to look further. So when I go back, I find out that, well, her PT may have been slightly elevated in the past, but not her PTT, right? So we want to do aPTT mixing studies. So the patient's aPTT is prolonged. Control aPTT is normal. We mix control and patient, and we're finding out that there is no correction, so an inhibitor is present. We get control PTT at 60 minutes, and we mix with patient PTT, and we're finding that 60 minutes later, there's significant prolongation of the PTT. So there is an inhibitor present. Now we want to ask, is this an inhibitor of factor 8, factor 9, or factor 11? So we look first of all at factor 9, and factor 9 levels are normal. And we look at factor 8, and oof, that's 1%. That's pretty significantly low. And so what we have here is a patient who actually has factor 8 inhibitor disorder. A little bit surprising, because initially we had thought maybe this is just all the Apixaban, but she actually does have an underlying factor 8 inhibitor disorder. All right, so one of the things I want you to think about in a patient like this is the bleeding disorder acquired or congenital? Does the disorder affect primary or secondary hemostasis or vascular function? Is the clinical picture fully explained by the anticoagulant alone? And in this case, we saw that it was not. All right, that ends our coag vignette on an elderly woman with factor 8 inhibitor disorder. See you next time.